Gold participants and listeners from around the world. I'm Kristen Schwartz, licensed midwife and MC for Gold Learning. And I'm here today with Dr. Kathleen Kendall-Tackett. Welcome, Kathleen.
Thanks so much, Kristen.
It's so wonderful to have you here, and thank you for taking time out of your busy day to sit down with me and chat a little bit about your upcoming presentation here for the Gold Lactation Online Conference 2019.
Well, I'm happy to be here.
Tell us a little bit. Let's start off with tell us a little bit about yourself. Where in the world are you? And tell us a little bit about your background. I know many of our listeners know you, have been to presentations, or even have a book of yours. But for the ones who do not know as much about Dr. Kathleen Kendall-Tackett, what can you tell them about you?
Well, I live in the Texas Panhandle, where I've lived with my family for the last 10 years. I'm actually originally from the state of California. My husband and I both are. And before that, we lived in New England, Massachusetts, and then New Hampshire. So we were there for 21 years. So we've actually lived a lot of different places in the United States. But where we are now is actually closest to the New Mexico border. We're actually not particularly close to anything else in Texas because we're clear up at the top. So we're about 50 miles from the New Mexican border, and we're at about 3,700 feet, so we're in the high plains. It's actually a very nice area. You know, we tend to have a lot of good sun and stuff. But yes, we've had a pretty cold winter. I know you asked me about that in the earlier interview, and we've had a surprisingly cold winter and a fair amount of snow. But we're looking forward to spring. I'm starting to see things budding out on the trees, and I'm very happy about that.
And the vegetation, is it more like desert-like
Yeah,
there
yeah,
where
it
you live,
is.
or how can we
It's
how
high
can we think?
desert, so it's kind of like
Hmm.
plains and
High
and
desert.
and sort of bluffs. And we don't have a lot of trees. The
Hmm.
trees aren't sort of native to this area, except for things like mesquite trees, which are kind of tend to be sort of shorter and kind of more spiky. Um, you know, People grow trees around their house,
Right.
but yeah, so it's more like wide open sky and bright red dirt and sort of
Mm.
green sagebrush, and I think it's actually really
Cool.
very pretty. It's a beautiful kind of effect. We have these incredible sunsets, that just cover like a whole. You feel like you're in a dome, with just a sunset completely surrounding you.
Mm-hmm.
So it's actually it's I think it's a very pretty part of the country.
The area, yeah. I've not been to that particular area. I've been to New Mexico, and what I found stunning there was
Yes,
those
yeah.
wide open
Okay,
areas. The
that
blue of the sky is so blue.
yeah.
That what you
Hmm.
described as the red dirt is so the colors are just wonderful and amazing. Is that
Yeah,
how we
I
can
think
picture
that's
it?
exactly how you can picture it because, like I said, we're very close to that, and we're right on Route 66 is another one of our kind of landmarks. So a lot of people kind of come through because they're doing, sort of the Mother Road tour of the U.S. So we're part of Route 66. That goes
Right.
actually right through the middle of our downtown.
Hmm. Interesting. Well, now tell us a little bit about your background. What are you up to these days?
Well, my background is in health psychology. I've been in that field for over 20 years. My PhD is actually originally in developmental and social psychology, but I kind of found, a few years ago that health psych was actually a better fit for me in terms of the things I was interested in. And it really, for me, was a very good explanatory model for a lot of the stuff I was seeing. And I've been a family violence sexual assault researcher since 1983. So that's been kind of always my primary field. And so for now, actually, what I'm doing is I'm working on, the two journals that I edit, and we've just finished actually I edit the journal Psychological Trauma. We've just finished a special issue on trauma in the military that I'm real pleased with. It's very, very interesting what's happening in the trauma field these days, and I really find myself applying it to a lot in perinatal health. Like some of the things that we can learn from combat vets, I actually think actually have a lot of application
Hmm.
to what we see that goes on, especially for care providers. One of the things I'm actually very interested in these days is something that comes from the combat literature is something called moral injury, and it's the type of thing that happens to combat vets when they're forced to do something that they believe is wrong, or they didn't stop something that they
Mm.
believed was wrong. And I thought that's
Wow.
such an interesting thing to sort of apply to care providers, especially around
Yeah.
birth, because we've got a lot of good research, especially from Cheryl Beck, showing that um, birth care providers, oftentimes are traumatized themselves, because they've observed traumatic
Hmm.
births, and the theme that came up, like in her
Hmm.
nurses study, was, feeling like I failed my patient. I didn't do enough to try to stop, what was happening. And I thought
Right.
that actually, that moral injury model, I think actually fits that kind of reaction better than a straight PTSD model, which is based more on sort of danger. And I thought that's actually, I mean, so that's actually
Right.
what I've been kind of really intrigued with lately. And I've been kind of trying to think how I can sort of wrap this
Wow.
into like understanding, what happens with care providers, because I really think that, we've got some significant issues around, how we do maternity care in this country. And I'm sure you probably agree, and I
Right.
think what's
Absolutely.
happening to our
Absolutely.
providers, I think in those settings. And I don't think we've had a
Hmm.
good explanatory model for it. And I was really kind of struck with when I was working on that combat and trauma in the military issue. I didn't expect to find something about birth in there, but there it was, donk, and it hit me like
Yeah.
in the
No.
head. And it was like, wow, wow, I think this actually fits. So that's what I've been actually kind of like really kind of thinking through lately. I've
Yeah.
been kind of excited about it.
Fascinating. Absolutely fascinating. And how the way you explain it, it makes so much sense. So you have to come back and present for us on this. Now I'm already excited. I want to
Yeah,
find
it's
more
it's
about
it's
it.
really interesting. It's kind of one of those kind of emerging constructs in the trauma field, and I was thinking, wow, that's just I think this is so
Yeah,
relevant to what we do in perinatal health.
absolutely. 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 And Kathleen, you have such an amazing background. You are an author of many publications. You even the owner and editor-in-chief of your own press, Preclaris Press, and recently you won an award, the President's Award in 2017 for outstanding service in the field of trauma psychology. That's
Well, that,
just
that I
amazing.
was actually rather thrilled for
Congratulations
that
on
one.
that.
Yes, but I was actually one of the people who founded, with a group of other people, founded the trauma psychology division, and it's really been gratifying to see it grow. We it took us
Hmm.
6 years to even become an official division within the American Psych Association, and to just see that field take off the way it has, it's been so
Yeah.
exciting to see.
Wow. Oh, so much good work you're doing, and so much for us to learn. It's always a pleasure talking to you. I feel like I just sit down with you for 5 minutes, and I feel like, wow, I've already learned so much. My
Thank
eyes
you.
are open to new subjects here. I wish we could talk for hours here. But now, let's talk about your presentation, the one you have for us here at the Gold online conference, the
Okay.
Lactation online conference of 2019, and you're presenting on lessons to learn from fat is best, how we can
Hmm.
improve our care. And I can already imagine the emotions running high when we're thinking of, some of us
Hmm.
might think, ooh, fat is best, and then somebody else is saying
Right.
breast is best, and that can be
Oh,
quickly
very.
very
Yeah.
emotional, you know.
Well,
So talk about
well,
your
it's
presentation.
Well, I think what I wanted to do in this talk is, look at the issue of, the organization Fed is Best and kind of try to figure out how we can improve the care we provide for families. And it's like, honestly, some of the information, on their site is kind of hard to read, truthfully, because it's like it's stuff we kind of, we tend to in the lactation field sort of disagree with, and we can sort of pick it apart. But part of it came from an editorial I'd written for Clinical Lactation, where I said, what can we kind of learn from this group? Because, when you really kind of step back and you kind of look at what they are saying, what you really see, especially with the founder, is somebody who massively fell through the cracks. She had, described, her experience as a new mother and how, she kept going to providers and saying, I'm having trouble with this. The baby's on all the time. He's crying you know, it's not comfortable. I mean, there was just a number of red flags that everybody missed. She talked to a pediatrician, she talked to a midwife, she talked to, lactation people at the hospital, and everybody missed it. Everybody. And it really, ended up with a tragic result. So now, kind of their push is to, make sure that, that early breastfeeding is, sort of supplemented and that babies aren't basically starving. And so again, like I said, some of the rhetoric is fairly inflammatory. And actually, that the first editorial that I wrote was about that. It was talking about, there was an article that was saying, the Baby Friendly Hospital Initiative was a human rights violation. And it's like, that's pretty inflammatory kind of rhetoric. But again, like I said, what I really wanted to do is, pull back and say, okay, but yeah, what's kind of the bigger issue here? And I think one of the things we see, especially in the United States, we see initiation rates, are really pretty decent, but we have this incredible melt off, so I think it's pretty apparent that, many mothers are falling through the cracks, and I think that you see that, in lots of countries around the world, so it's kind of like it does kind of say, gee, you know, we probably aren't offering the type of support that the mothers need. But the other thing is, we want to make sure that providers at all levels, feel confident in identifying, mothers who may be at risk for having difficulties, and not to scare them, but to just come alongside and say, okay, so this is going to be a mother that needs some extra support, because there are a number of risk factors, including ones that don't even exist before she actually has her baby, because the birth interventions themselves oftentimes can trigger some of these problems. So what we want to do is kind of have providers feel more confident, providers at every level, but we also want to encourage them to really listen to mothers, because I think the thing that becomes apparent in these stories, and there's a bunch of different stories on the website, but I think the things that become very apparent is nobody was listening to the mothers. Everybody was just sort of patting them on the head and saying, yeah, yeah, that's just normal new motherhood. You're doing fine, even though the mother really sensed that she wasn't doing fine. Now, sometimes, reassurance really is the best thing, but I think sometimes we're a little quick to do that without investigating. It's kind of like when you've got a really exhausted mother. It's kind of like I think you should ask a couple more questions. What else is going on? I recently had a situation where it was a grandmother called me, and her daughter was at very high risk for postpartum depression because, a number of different things that happened to her. And this poor young woman, she was exhausted, like all the time, but refused to go see any kind of mental health provider because she was afraid she was going to be told to wean. And she was just adamant. And so she was just sort of almost barricading herself and absolutely kind of not wanting to even talk to anybody about it. And so, one of the questions, and the grandmother was very concerned because her daughter was just exhausted. And so, one of the things that I asked is that, I started asking her some questions about, okay, so where's this baby sleeping? And if the mother's kind of getting up in the middle of the night, they are going to be more tired, versus the baby is nearby and they can just kind of nurse and then go kind of back to sleep. Um, so that was one of the issues. The other thing is, the baby was late preterm, so, those babies kind of tire out. So they go suck, 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 and they fall asleep. And so, what are some kind of things we can do, with that mom, and I actually taught the grandmother a couple of what I call breastfeeding hacks, kind of how can we get a little few more calories into that, so again, like I said, sometimes if we just ask that next question, we ask the sort of deeper question, we can sort of head off some of these problems, and also know what to look for.
Now, let me ask you this. In which, strictly speaking, here from the standpoint of the United States, I don't know exactly how it is in other countries, but let's say a mother comes home with a baby, experiences problems. It feels
Mm,
like she's almost like in a void. The next follow-up visit isn't until a few days from there. The care providers
mm.
are not asking the right questions. So is more like a system failure in general, or are the care providers overworked? They see too many clients. Where is the issue?
Well, I think actually you've kind of, you've named two really key issues. I think that, I think in the United States at least, that, the guidelines are changing so that mothers are seen sooner
Hmm.
than 6 weeks, but they're still like 3 weeks, and
Right.
they can get into a lot of trouble in 3 weeks.
Mm.
Um, but the other thing is that, there just isn't, there aren't the resources in the community,
Mm.
that these mothers need. What's actually kind of interesting is, I remember seeing something, I don't know, a few years ago, but they were talking about how, a lower income mother in the United States is more likely to have good breastfeeding support, through like WIC, because WIC does a
Mhm.
fabulous job, versus a middle class mother who's going to have to sort of patch, together stuff. And, oftentimes, especially in hospitals, hospitals tend to be vastly sort of understaffed in terms of
Mm.
lactation support,
Absolutely.
because they give ratios of how many, lactation consultants you need per number of patients or number of births,
Right.
and oftentimes they're very, very short. And, I talk to lactation consultants all over the country, and this is a comment that many of them share with me about how they just feel like, it's just an impossible workload, that
Hmm.
they don't get to practice the way that they want to practice, because they don't have the resources. They have to do it as quickly as possible, and oftentimes there's maybe not coverage on the weekends or in the
Yeah.
evenings, and so I think some of it are there's some major systemic things that are going to happen. There has to be kind of a commitment at sort of a high level, to make sure that there's adequate staffing, and also that there's a good referral network, out in the community so that these moms, have lots of different types of
Right.
resources. So I think, it is something that, has been lacking for a long time, and it's something we need to be, really thinking about.
Hmm. Absolutely. Before I let you go, my last question to you is, what are you hoping the delegates will take away from your presentation?
Um, what I'm actually hoping is that people at all levels of care will be asking questions about how they practice. And this is not to point fingers at anybody or to say, oh, you did this wrong, but it's more like, how can we do this better? How can we improve? And to be like looking at this as kind of a positive thing. It's like I've been taking this business course this year, and actually one of the books we read was all about, this book was called, The Beautiful Question. And it was all about how questions can spur innovation. So I'm hoping that this will spur some questions, that we'll start looking at every level of care. And this is something that people within individual practices can actually do themselves. They don't even have to wait for it to become sort of system wide. It's kind of like, what can you do in your practice to make this better? And I'm hoping that this will actually lead to some creative thinking
Mm.
about how we can best provide the support the mothers need. But also too, like, what kind of education do you feel like people at your institution need,
Right.
in order to really kind of spot these mothers?
Hmm.
Because we know there's known risk factors for
Right.
some of the problems that came up in the Fed is Best. And again, like I said, even things like, the birth interventions, even
Mm.
things like, let's say, for example, epidurals, which, the majority of mothers in the United States
Right.
have.
Mm.
So how should we be following them, and what kinds of things? And how can we also better empower the mothers?
Hmm.
And I think we have to walk kind of a fine line between empowering and scaring.
Mm.
And I think where I think the Fed is Best site makes a mistake is, I think they're very frightening.
Right.
They have a lot of, my baby died because,
Yeah.
and it's like, that's frightening, especially a new mom who's very, very suggestible.
Oh,
That's going to be,
absolutely. Yeah.
that's going to be a hard thing for her to sort of contemplate. And we don't want to have it be that sort of fear-based system. But what we want to do is, okay, you know, hey, mom, we want to partner with you. Here's some things to watch for. And if you see this, I want you to call us right away. So thinking about kind of how we can empower the moms and how we can actually better
Mhm.
empower the clinicians. That's really kind of what I want to be the sort of takeaway.
It sounds absolutely fabulous. I can't wait for the presentation. And thank you so much, Dr. Kathleen Kendall-Tackett, for sitting down with me here, chatting about your research, your work, and about this upcoming presentation.
Well, thank you very much, and I'm looking forward to it.
And now to our listeners, the presentation Lessons to Learn from Fat is Best, how can we improve our care, is part of the Gold Lactation online conference of 2019. For more information on this presentation, which is being held live on April 24th, and for the other presentations in the conference, please visit goldlearning.com. Thank you everyone for listening. Bye.